I'm Marty Goldman. We sometimes are lucky to have sort of the perfect storm. The topic of today's controversies in cardiology is so appropriate for this season of festive meals, big meals, high caloric intake, the treatment of hyperlipidemia. One of the important things that we strive to do is to try to match our panel to the topic and to the speaker, and we're very privileged today to have really a world's expert on the topic of hyperlipidemia, Dr. Dan Rader from University of Pennsylvania. Dr. Fuster will tell us more about him. Dr. Robert Rosenson, who's professor of medicine and director of cardiometabolic disorders here at Mount Sinai, will be the moderator. The panel will be Sanford Friedman, who's associate clinical professor, Donald Smith, who's an endocrinologist, associate professor of medicine and community medicine, director of lipids and metabolism in the Heart Center, Ben Hirsch, who's a senior fellow with great interest in the field of lipids and has done some very good work in that field already as a fellow, and Juanjo Badamon, who's been a pioneer in atherosclerosis and atherothrombosis research. The fellow's monograph, Hadi Hellerson, who is put together the monograph, actually focused on a very, very interesting controversial area, complications and side effects, sort of, are they hype, hoax, or are they real? Many patients who resist taking it or take it and want to stop taking their drugs because of the so-called side effects. So he's going to give us insight into it, but Dr. Rosenson's panel questions are going to cover a much broader aspect of treatment of hyperlipidemia. Hadi?
Thank you, Dr. Goldman. Thank you, Dr. Fuster, and welcome again, Dr. Rader, to Mount Sinai. Thank you again for a great talk this afternoon. So when I was a medical resident, I made two big mistakes. I probably made more, but the two biggest ones I made were trying to be my mom's doctor, and second thing was teaching her how to use the internet. A few years ago, she called me to tell me that her bad cholesterol was high and that her doctor wanted to start her on a statin. She asked me if I agreed, and I said I did. A couple of weeks later, she called me to tell me that, you know, Hadi, I'm going to stop this statin. And when I asked her why, she said, well, I went online and I Googled the side effects, and I think I'm having them. And then she goes on to tell me that she's blamed her fatigue on the statin, she blamed her weight gain on the statin, she blamed her hair loss on the statin, she blamed my dad's erectile dysfunction on the statin, and he wasn't even taking one. But on a serious note, I share this story because it highlights important issues on the treatment of high cholesterol. First, how do we decide who to treat? And second, what do we know about the side effects of statins? And third, when do we call a patient intolerant to statins, and what do we do about it? So over the last 10 years, the number of people on statins has risen dramatically. In 2014, about 25% of adults over the age of 40 were on one. And the new guidelines of 2013 promised to increase this number by about 12.8 million. That's exactly almost the size of the state of Pennsylvania, by the way, Dr. Rader, since you're from there. This increase is a result of the controversial paradigm shift of who we decide to treat. Instead of chasing LDL levels, the new guidelines base their recommendations on cardiovascular risk, with moderate to high intensity statins becoming first-line treatment for many patients. This is important because large observational studies tell us that about 20% of patients on statins experience their side effects, the majority of which are related to muscle complaints. As we lower the threshold on whom we decide to treat, we will only be seeing more and more of these side effects. So what do we know about the side effects of statins? On any given week, you'll probably find a news article published about a new discovered side effect of statins. Just 2 weeks ago, the New York Times ran an article about how statins reduce the effectiveness of the flu vaccine. For patients, it becomes very hard to separate the myth from the medicine. And what we know from large studies and meta-analyses is that statins are quite safe, but they do have some side effects. We now know that statins do indeed increase the risk for diabetes for some, and these people are at risk for diabetes anyway. We know that statins likely don't cause any memory loss or cognitive impairment. At one point, people thought statins can help treat cancer, or at another point, they thought maybe statins cause cancer. Now we know that neither one of these are true. But we do know that statins cause a myopathy. And what makes the issue of myopathy controversial is that the number of patients reporting this myopathy in clinical trials is much lower than what is seen in clinical practice. In some randomized trials, the rates of myopathy are near 5%. But in a lot of observational studies, the number of patients complaining of these symptoms ran between 10 to 20%. And 1/3 of the people with the myopathy say that they interfere with their daily function. So the myopathy is real. But what do we do about it, and when do we call a patient intolerant? Despite the number of patients reporting muscle symptoms from statins, the data suggests that more than 90% of patients who don't tolerate one statin will tolerate another. Still, there's a significant number of people who won't be able to tolerate any statins, and there are different strategies that have been proposed to deal with those patients. One example is alternate day dosing, but randomized trials have shown that that isn't effective enough to reduce your LDL to goal. In the era of PCSK9 inhibitors, the issue of statin intolerance promises to become more interesting. While they're not approved for patients who are intolerant to statins, I'm sure they will soon be. So what about my mom? I actually could never convince her to take a statin again, and I can't blame her. The media coverage of statins scared her away. And unfortunately, this is true for many patients out there. In the latest issue of the European Heart Journal, a study from Denmark found that patients exposed to negative news about statins are more likely to stop it and are more likely to suffer the cardiovascular consequences of it. In the shifting landscape of treatment strategies and drugs that are available, it behooves us to understand the side effects, know the data behind them, and learn how to properly manage them. Thank you.
Did you tell your mother what you were going to say? Did you talk to your mother today? Otherwise, I will call her and say, you did very well. Anyway, it's a pleasure today to introduce Dr. Rader here at Mount Sinai. Dan Rader has a very spectacular career. Actually, he obtained the MD degree at the Medical College of Pennsylvania with summa cum laude. And then he moved to Yale, where he actually had his internship residency, and he was chief resident of medicine there. Then at that time, he moved for 3 years to NIH, where he was a medical staff fellow on the molecular disease branch. And then he became a staff scientist at NIH, and finally in 1994, he moved to the University of Pennsylvania, where he was assistant professor of medicine, and he moved into the ranks of 4 different professorships. I've never seen this before. The professorship Edward Cooper, professorship of medicine, professorship of pharmacology, professorship of medicine and genetics, and the Seymour Gray Professor of Molecular Medicine. That's unbelievable. 4 professorships. Again, I have never seen this before. Anyway, this is the beginning of what I have to say to you. Now, he started actually in 1994 when he moved to the University of Pennsylvania as director of preventive cardiovascular medicine. Then he became chair of experimental therapeutics and the director of clinical and translational research center, and finally the chair of the Department of Genetics at the Perelman School of Medicine at the University of Pennsylvania. That's where he got one professorship after the other as he was moving forward. Well, he has a great job there, and then his career is full of awards and other things. In terms of the awards, it's the Outstanding Faculty Award in Pennsylvania, Outstanding Teacher Award. Then he was elected American Society of Clinical Investigation, the Doris Duke Charitable Foundation Distinguished Clinical Investigator Award. The American Heart Association gave him also the highest award of the Atherosclerosis and Thrombosis and Vascular Biology Council, and then an award in Kentucky, which is very important, the Jill Hart Institute Award, William Osler Patient Oriented Research Award, and so on. And he has been the chair of a number of programs across the country, research programs, which I don't want to waste time here in mentioning all of them. And now come the bad news. Editorial and peer review activity. He's in the editorial board of Attention Molecular Medicine, Arteriosclerosis and Thrombosis and Vascular Biology, American Journal of Physiology, Circulation Research, Journal of Lipid Research, Journal of Clinical Investigation, Arteriosis, Thrombosis and Vascular Biology, and he didn't write that he's section editor of JACC. How you feel? How do you feel?
I feel very bad.
Can you imagine that? Section editor, and he just ignores completely in his curriculum vitae. I will notify the higher ups today. Anyway, he actually has had 11 NIH grants, which is also unusual. And then he has near 500 publications. And I must say that if you really look at the advances in the lipid metabolism over the years, it comes to mind three institutions. One is Columbia here in New York. The other is UCLA in Los Angeles, and the other is the University of Pennsylvania. I don't think anybody could challenge that. And obviously at the University of Pennsylvania, he has been the driving force and continues to be. So I appreciate very much visiting us today, and I hope the next discussion is going to be helpful. I must say I spent the last 3 days with a huge meeting in New York, and I decided to sit down here and just relax and listening rather than being involved. Anyway, thank you very much for your visit. Thank you. Now we are going to ask all the protagonists of this. The what?
Do you want to give him his plaque?
Yeah, okay. I will do it in my way. Dr. Goldman is so much driving me from morning to evening that for once, let me do it in the way I want. Let me give the plaque. And then the Sharma is the father, Dr. Sharma, and then the Simon Duck, which you remember him well. Okay.
Yes, thank you.
Thank you
you
very much for visiting.
Thank you,
us.
Mel.
Wonderful. Okay, you can sit in the middle. Hey, yeah, you're there. Now we have all these panelists: Sandy Friedman, Dr. Vadimon, Juan Benjamin Hirsch. Yeah, a big shot. Hey, just. Don Smith, and then it was Hadi. Did you see how he's dressing, Hadi, today? He's like a real. Just look at him. Okay, Dr. Rosenson, you are the one who's supposed to moderate, and good luck to you.
How are you?
Okay, we have a lot to cover, and I'm going to ask the panelists to keep their responses brief, because there's a lot of issues that really need to discuss in the lipid field. Let's start off with the guideline, the ACC/AHA guideline, evidence-based guidelines that have resulted in a lot of controversy, walked away from LDL cholesterol targets. And, Dan, why don't we start with you and give your perspective about this change in the guidelines that, are no longer making decisions based on LDL cholesterol levels or titrating to a certain LDL cholesterol target?
Well, I have to say I had some major issues with the guidelines. So in the spirit of a controversy session, I actually had initially been on the NIH panel before they turned it over to ACC and AHA, and I did resign partly because I saw the direction that it was going. And I really, in particular, disagreed with the decision to abandon the targets. The targets have been with us for a long time. They've been very useful in, I think, driving physicians and patients to be more aggressive with LDL. I personally feel lower is better. There's a total body of evidence that strongly suggests that. We could talk about how low, and we probably should, and that doing away with targets confused everybody, in particular with the PCSK9s coming along. And now that they're here, everybody's confused about who should get them and when they should be used. So that frankly was my thought about that.
Well, I completely agree with you. I wrote 5 single-spaced pages to Gary Gibbons when I was asked to review the document, and I later spoke to Neil Stone, who didn't like my responses, but they certainly led to a lot of controversy, and I think Scott Grundy will be the savior, for the next set of guidelines. So when you think about starting somebody on atorvastatin 80 milligram daily, unless they're 75 years of age or older, and then they did a hedge of 40 milligram of atorvastatin or the equivalent rosuvastatin, Ben, I'd like to ask you, what are some of the challenges that we encounter in putting somebody on high-intensity statin?
So, I think you have to kind of think about the context in which you're starting the high-intensity statin, because if it's after an MI, you really want to do a high-intensity statin, because the benefits of high-intensity statin accrue within 6 months, and it's about 25 to 40% in reduction. So in that context, I think starting high-intensity statin is something that really should be a priority. In the primary prevention cohorts, I think that it's probably better to you could have a lower threshold for starting a high-intensity statin, and you could start more moderately. So I think it just kind of depends on the context of what you're doing.
So we have the evidence-based therapy, and then there's been a lot of very important imaging work done here at Mount Sinai, talking about some of the acute effects, and maybe, Juan, you can talk about some of the acute effects of statins on plaque morphology, inflammation, to try and help let everybody in the audience know why we need to start with this therapy.
Yeah, I mean, the effects on plaque that are not very acute, you need to treat the patient for a significant period of time. But what you will see, and in collaboration with Zahi, with imaging, basically, you don't see so much regression of stenosis. What you see is changing in the composition. Mm-hmm. And if you remember, and if you believe in the school of the vulnerable plaque, so what you do really, you more stabilize the plaque that is potential to be ruptured and generate an acute event. This is in the wall. Obviously, we cannot forget that there are a lot of evidences suggesting that statins also does a significant non-lipid mediated effects, and probably you cannot rule out the possibility of these non-lipid mediated effects of statins to be some partially responsible for the huge benefits that you see in all the phase 3 in the clinical life.
So Sandy, in clinical practice, you place somebody on atorvastatin 80 milligram, they're in the hospital for ACS, and do you ever down titrate the statin if they don't have side effects? What advice do you give to your patients with regards to maintaining the evidence-based therapy?
Well, I'm a little embarrassed to answer that question because I sound like Donald Trump when I say this, but my patients don't get heart attacks, so I don't see them in the coronary care unit. And basically, I use kind of a homegrown algorithm developed over 10, 15 years using particle numbers, LDL, and imaging, and making good close contact with the patients, and they just don't get into trouble. So, I really don't see too many of that.
Lonnie, as a fellow, I'm sure you're seeing a lot of hospitalized patients, and what kind of advice are you giving to the patients that you're seeing on service when you're starting on the high-intensity statins? Are you saying that they go home and then they can down titrate, or should they remain on high-intensity statins for a longer period of time?
Well, as Ben was alluding to as well, it really just depends on the clinical context of what kind of patient I'm seeing. If it's someone who suffered an MI or ACS, I would stick with the high-intensity statins. If they're in the hospital for non-cardiac issues and they're on a high-intensity statins and they don't need to be, then maybe down titrating would not be a bad idea. But I personally do prefer the higher intensity statins if there are no side effects.
Okay, so the TNT trial showed benefit out to 5 years, and there, were negligible side effects between, atorva 80 versus 10, some difference in transaminases, but statins have never caused liver failure, maybe an incidence of 3 in 1 million compared to the background 1 in a million. But I think that we really need to support the evidence base, and in these individuals. You know, it's not a short-term horizon. A lot of these people will be rupturing plaques. Actually, I'd like to divert the discussion. There was a very interesting study by Mega that showed that with a gene score based on HMG polymorphisms, you could identify people that derive more benefit from statins versus less. How close are we to personalized medicine, Dan? What are the steps that are going to be necessary to try and get, genetics into, routine clinical practice?
Well, that's a big question, Bob. But let me reduce that question to the specific issue of the decision to use a statin, which is kind of the way you introduced it. So, in my opinion, we underutilize statins, and in particular, we underutilize statins in younger people for the benefit that they have over a lifetime. And again, this is one of the bones to pick I have with the guidelines, that we really basically have no guidelines for people under 40. And yet some of the people who could benefit the most from statin therapy would be people who are very high risk, who are younger. Of course, FH would be one, but what about those people who are at strong genetic risk for developing cardiovascular disease due to family history and genes? Leading to my view that, in fact, with more and more data, we're going to get to the point where a genetic risk score actually does give information about lifetime risk of cardiovascular disease or coronary disease that actually helps us make a decision about who should go on a statin at a younger age, even if their LDL is not particularly elevated. And I think, again, it comes down to what is the burden of evidence that's required for that. But I do think that we're headed there, and that will be one of the things that will help us guide that decision. I'd love to see a clinical trial initiated where people at high genetic risk but normal LDLs are randomized to statin, no statin, and followed for 20 years, but it's a long-term trial.
So we presented data at the European Society of Cardiology with a full Medicare database, started with 1 million myocardial infarctions, and we looked at patterns of down titration, discontinuation. And if you received a high-intensity statin for at least 30 days to 182 days, we then looked at down titration, discontinuation. You down titrate and discontinue after you had been hospitalized for a myocardial infarction, you have a higher burden of cardiovascular hospitalizations, higher non-cardiovascular hospitalizations, and you're more likely to die. So, this is a paper that I'm writing up, and I think it's compelling. It's long-term therapy, high-intensity statins. Now, what about ezetimibe, Don? You get referrals for people that have been in the hospital with ACS. They're on high-intensity statins. And when do you introduce ezetimibe? What are your parameters?
Well, you use them in people who you are sure are not going to take a statin if you give it to them. So it's a first sort of trial after you get to the problem patient who won't take anything at all. And second of all, there are some people who get better than the 20% in terms of risk reduction. They can get 30 or 40%. And so, you can do studies and tests to check on that, but it's best just to give the drug and try for 6 weeks. So those people certainly, and always with people who are limited in their statin dosing or in 3 days per week, you always give ezetimibe before you do anything else. Then you've got them ready for a PCSK9 because you've now can't get them to where they want to be, and they have coronary disease, and so now they fit into the new FDA guidelines. So that's how I use it. It's wonderful that the Improve It trial showed finally down to 54, you still get reduction in events. So some of the old guidelines in terms of the levels just have sort of, they keep going down. And now with the PCSK9s, as a side effect, they seem to be even getting lower as the LDLs are going much lower than even in the mid-50s. Okay.
So the clinical trial data helps us, and what about genetics? And maybe Dan can take this one on the NPC1 polymorphisms, and then the Ference trial, which was published in JACC, that looked at HMG polymorphisms and NPC polymorphisms. How do the genetics help with this story?
Well, genetic variants can be a tool to assess how loss of function of a gene, product, a protein impacts on outcome. And that was one of the great things about NPC 101. Even before we knew the results of the Improve It trial, we learned that heterozygous loss of function of NPC 101 not only lowered LDL, but actually protected from coronary disease. If we hadn't known that, if we hadn't already had ezetimibe and that trial was ongoing, that would have given a lot of confidence in this target as a new target. So I do think that, in particular, this sort of thing for identifying new targets for therapy can be very useful. Yeah.
It was confirmatory, and it was nice to see that both genes had an additive effect on cardiovascular events. I think a very nice paper published in JACC. Well, we're very excited about PCSK9 inhibitors for a whole host of reasons, and the FDA has approved them for LDL cholesterol lowering in homozygotes, with at least one of the agents, heterozygote FH patients, and coronary disease patients with LDL cholesterol levels not sufficiently lowered, with maximum tolerated therapy. So Sandy, are you recommending PCSK9 inhibitors for any of your patients, and who would those be?
Well, it's interesting. I have patients who I try statins, everything else, and we don't get to target. And I have patients who just don't tolerate any statin at all. In fact, they don't tolerate resins. They don't tolerate anything. And it's been approved. The drug reps have worked with us, and we've gotten those patients approved for those drugs.
Yeah, so statin intolerance is not an indication yet, but certainly a population that's, I think worthy. And, we've participated in, a couple of those trials, and, hopefully there will be an indication. But certainly a lot of high-risk patients need something more. So Ben, what LDL cholesterol level do you feel is too high? Let's say you have somebody on atorva 80, ezetimibe 10, or at least, whatever statin they can tolerate at the maximum dose. What number makes you feel uncomfortable, or what clinical situation makes you feel uncomfortable?
So I think there are two primary clinical situations, actually three. So one is FH. I think that if you have someone with, even at the age of 20 with LDLs of 200 despite atorvastatin 80 and ezetimibe 10, you really want to get the cholesterol down further, and so I think that's a really good indication. Another is, and this is a little bit more controversial, but if they have a higher cardiovascular risk, just based on these risk scores, which in and of themselves are controversial, but right now we can, that's what we rely upon. And then certainly I think probably the most important, again, is after an MI. You really need to, we really need to get those levels down, get the LDL down. And of course, not to be too narrow. Of course, smoking cessation and blood pressure control are very important. But in terms of LDL goals, I would want them less than 70.
Okay.
Did you say goals? Just kidding.
So we'll learn a lot about that with the two ongoing phase 3 trials that are, including people with LDL cholesterol levels greater than 70 milligram per deciliter, see whether we get incremental benefit and what are the costs of the benefit or the number of patients needed to treat. Juan, can you tell us a little bit about some of the biology of PCSK9 and what do we know about the vessel wall, if anything?
So far we only know a little bit of the mechanism as you presented this morning, and we know that it's very good lowering biomarkers, LDL cholesterol. The question is that even though we always say that they are very safe and very well tolerated, the longest experience is 52 weeks. This is the longest experience that we have. And I am a little bit worried about to be so aggressive unless that you belong to the group of high risk of familiar hypercholesterolemia, either homo or heterozygous. Otherwise, I will still stay with the statin and ezetimibe. And if you allow me, let me be a little bit of controversy. As a pharmacologist, you always like to titrate, right? Because you want to make sure that the guy is not allergic to thrombin. But here everybody says that after an acute MI, you give atorva 80 because it's very powerful and you want to lower the lipids right away. If this is the rationale, why don't you give atorva on ezetimibe? It is more effective. What is the rationale for giving atorva 80 rather than titrate it, rather than be more aggressive and go all the way to the end?
Because you might get sued if the patient gets rhabdo.
Yeah, so we have randomized clinical trials. We've got the yellow trial that shows lipid surface going down in terms of the plaque. We've got Zai's study with Valentine showing a decrease in vascular inflammation in the carotid arteries. So we've got the RCTs and we've got the biology that would support hitting somebody hard, and that's part of the Medicare database. Will be one of the important outcomes is high intensity therapy for probably 6 months, maybe all that you need to get the benefit, at least based on, database, starting with 1 million people, and maybe lower doses after that 6-month period of time, as long as somebody adheres, maybe equally as well. But, during the time when they have the inflammation in the arteries, at least from my understanding of the literature, is where at least I'd like to use high-intensity statins.
Hey, Bob, can I, since you asked Juan about vascular biology of PCSK9s, and Juan earlier mentioned the non-LDL lowering benefits of statins, can I ask him a question in the spirit of controversy?
Of course.
So the issue of statins having a non-LDL lowering benefit, which does seem to be widely accepted, but I personally am somewhat skeptical. So if that's the case, and PCSK9s do not, which you wouldn't expect they would, right? I'm trying to be controversial.
Yeah.
So wouldn't the expectation then be that PCSK9s would have less risk reduction per LDL lowering than statins would? And is that what you actually expect from PCSK9s? I'm trying to push the button.
No, I agree with you because I am very simplistic. I always believe that cholesterol is bad because cholesterol gets into the wall and triggers inflammatory effects. So therefore, if you lower cholesterol anyhow, theoretically, if you reduce the pathological stimuli, you will reduce all the mechanisms related for that. So my point of view is that it doesn't matter if you do a good diet, exercise, of statins. And even though evidence-based medicine, the answer is I do not know. If my life depends on that, I will expect to see pleiotropic effects. Again, we call it pleiotropic effects because it's the regular code that we always use. But I think that if you lower lipids, you are going to lower all the mechanisms regulated for high levels of lipids. Call it pleiotropics or whatever you want to call it. But I agree with you. I expect to see effects in the endothelium. I expect to see effects on the platelets. And I expect to see regression of plaque and changes in the composition of the plaque.
Second to LDL lowering. Is that what you're saying?
Second, or a consequence of. This is the big discussion, but they go together.
So Don, of the people on the panel, you and I have probably the most experience with PCSK9 inhibitors. Can you, please discuss your experience, the patient acceptance of injections, and any concerns you have about the lowering LDL cholesterol level with these agents?
Yeah, at this point, we have just tons of people now coming in because we've seen people over the last 3 or 4 years and sort of made a list of them who just don't get anywhere near the 70 that we're trying at least to get to, if nothing else. So they're now coming in, and we're now able to add that to whatever the medications they're tolerating and not getting to. So they're very accepting. The two companies both are just superb in helping you get these people started. And you should call them if you have any question or if you see a person and you want to start them yourselves. They're easy to show. They'll give you something. They'll show you how. You can show the patient. Once they see how to give it, they're all for it. There's not any reluctance that I've found in people wanting to take those things. So it's a wonderful time to have them. So don't wait to sort of wait on Robert and myself if you want to get them going. Try them yourself, and we'll be happy to help you. But you just call the numbers, and I think it's 1-844 Praluent or 1-844 Repatha. And both companies, whichever one you call, they'll be out and call the patient for you and get everything helped approved.
So we're waiting for the phase 3 outcome studies, post-ACS, stable coronary disease patients, and enhanced population. But we do have, phase 2 data, with both agents that showed, that events are reduced by about, 53%. Does this provide you any comfort, when you've got 4,000 or 5,000 people treated, for a minimum of a year? To see this kind of signal? Hani, maybe you can comment on that.
Well, I haven't used the PCSK9s myself, but I do think that it does give me comfort, and I think that we're heading from an era of statins to an era of PCSK9 inhibitors. I think that the response that Dr. Smith said about how patients are responding to it and how they like it, I think that's more and more going to be the trend rather than just the exception. So I'm quite positive about all the data that's coming out.
Yes, we need the clinical trials to evaluate cost effectiveness, and I think that'll be very, critical, to their widespread use.
Yeah, Robert, the 47% decrease sounds enormous, but the numbers needed to treat are 1 in 100. Mm-hmm. You need to treat 100 people to get that one sort of down because it's very small as you get lower and lower. So just to let you know that you have to look at numbers needed to treat as well, or the absolute risk reduction. 1% as opposed to the relative risk reduction. It's just extraordinarily important.
And the other thing is, this is a great drug if you belong to this group, that you are intolerant or you are non-responsive to statins or you are familiar with hypercholesterolemia. If you are a normal guy, remember that even though you say you lower at 60%, but this morning was said by Dr. Reller, it's very difficult to go from 90 to 60. And in addition, the benefit from 90 to 60 is not the same benefit that you get from 250 to 100. So that when you go to the cost benefit, you have to be sure that when you are in a certain low level, number one, it's very difficult to go lower, and second, the benefits are not as great as expected.
Right,
But again,
so-
remember, if you belong to these subpopulations, you have to go for it and start as soon as possible, but not for everybody. I think that we have a lot of tools before to start giving
Yeah.
PCSK9 to everybody.
Yeah, so that's where the clinical trials are going to be, crucial, to look at these increments above 70 milligram per deciliter and look at the benefit and what the costs are to get that benefit. So, that's why we're participating in at least one of the trials for you. Dan?
Bob, can I ask you and Don, what do you tell patients when they ask you about the side effects of these drugs? And specifically, do you mention the neurocognitive signal for both drugs and run the risk of what Hadi described, as someone getting in their mind that this drug might cause neurocognitive side effects, or do you tend to be silent on that and sort of wait to see what happens?
Well, I'm not too familiar with, what are the neurocognitive side effects?
So there's a very slight imbalance on the adverse reporting about neurocognitive impairment, but it's a very, slight imbalance, and both companies randomized 2 people to active therapy versus, 1 to placebo. It's an issue that we're looking at with PCSK9 variants to look at there's a genetic association or not. We also know that it's being evaluated prospectively in the Ebbinghaus study, which is embedded in the Fourier trial with very detailed neurocognitive, assessments. But, obviously from discussions that I've had with Valentin that he's brought up at this controversy meeting, we feel it's worth, studying it. But when we talk about, cognitive impairment with statins, statins do cross the blood-brain barrier, monoclonal antibodies don't. And then, one of the issues that was discussed today is, the glia cells, manufacture their own cholesterol, and the brain's not dependent on, hepatic cholesterol. And I don't know, maybe, Dan, you want to comment a little bit on that biology, or what's your, your perception?
Yeah, I agree with Hadi's conclusion. I don't think statins cause cognitive impairment. If anything, the data that exists suggests, if anything, there may be a slight benefit. I think the jury's still out. Personally, I find it unlikely that PCSK9 inhibitors have a neurocognitive effects, and I think it's probably just a statistical artifact. It's not even statistically significant, so we'll see. I think my question had more to do with the art of medicine. You feel, on one hand, obligated to tell patients about a new drug, especially something that's new, when they ask what are the side effects, to give them full disclosure. On the other hand, I do think we run the risk of what you described, Hadi, is that people, once they get in their head that they might have a side effect of something that you don't even think is real, that then it's more likely to happen. So it was sort of that question I was sort of putting out there.
So when you review the literature, patients with heterozygous and homozygous FH are more likely to have dementia compared to, age and, sex-matched controls. And we have one of our patients whose mother has Alzheimer's disease. She's got heterozygous FH, extensive 3-vessel coronary disease, and she's afraid to take a statin because her mother has Alzheimer's. So I think that the issues that Hani brought up about the press adversely affecting patients' care and well-being is a valid one. So, Sandy, you mentioned you use other biomarkers. What is your perception about high LPA, and is that something that might interest you with regards to recommending a PCSK9 inhibitor?
No. I think the high LPA, when someone with coronary disease gets high LPA, it can be fulminant. But I have people with high LPA and the calcium scores are 0. I think we don't talk enough about imaging here. I don't know. If the calcium score is 0, the odds of getting in trouble, even with terrible lipids, is very remote. And if you have an intolerant patient, it gives you a little wiggle room. Not that you shouldn't, try to make things better. If you have a calcium score of 100, you have the same risk of having a heart attack as if you already had a heart attack. And what I use, the biomarkers I use the particle numbers, and I'm very surprised by them, particularly in the mid-range. Sometimes you find people with enormous particle numbers, you never would have expected it. When the particle numbers are close to way under, then the calcium score is invariably 0. I mean, there are all sorts of permutations. There's no time to go over them, but they're not that complicated. And the fact is, you can prevent large vessel events from happening with 95% success. It's amazing. It's amazing.
Sandy, if you had a patient who you felt should go on a PCSK9 inhibitor but didn't have clinical coronary disease and didn't have FH, so didn't have either of the two indications, would you consider doing a coronary calcium score and then using that as an argument if it was high that they should get the PCSK9 because they now are in a
Well,
secondary prevention situation?
Somewhat shamelessly, the answer is yes, because I get calcium scores on everybody. So, you know, I mean, why not? It's an X-ray, you know? It's not that much radiation. What's the big deal? You go get the picture, you know? See what you're dealing
I
with.
want to comment on that because I think to me, I use that all the time as well. And they now have a MESA calcium score index.
Right.
And you can go to MESA and basically you plug in not only the risk factors, the 18 or 12 for 12, but you put in the coronary calcium score. And the C statistics goes from about 0.75 up to about 0.82. And the reclassification, it's enormous. So I had a guy who just the same sort of thing. This guy should have been, his LDL was way off the charts. He had a 0 score. It just totally flipped things around. And so that can happen. And the question is, well, what about the carotids? And maybe you're missing out on those. But to me, the studies that have been done here, the great one in terms of looking at the carotid scores and the calcium scores, has shown they equally sort of contribute to risk. And so you can go ahead and then get a carotid if you want. And sometimes if they're so high and you feel the risk is so high, and you feel something, before you say, I will let you not take a statin, you need maybe to get both of those systems looked at, both with the calcium score and with the carotid ultrasound to make sure there's no carotid plaque. But I use those a lot. You don't use them apparently.
No, I'm a coronary calcium proponent.
Right, yeah.
I am curious whether the payers accept coronary calcium in order to
Yes,
then
that's
reimburse
the
for the
problem.
PCSK9.
Right.
I don't think we know the
Yeah.
full answer to that yet.
It's probably going to be
They
individual,
have,
but
in my practice.
They have?
Yeah.
Yeah.
all right, yeah, the FDA was based on clinical cardiovascular disease, but
Exactly.
really the insurance companies are the gatekeepers.
Yes.
So let's turn to HDL cholesterol. We know in the emerging risk factors collaboration that for every 15 milligram per deciliter increase in HDL cholesterol, the risk of a cardiovascular event falls by about 27%, and adjusting for non-HDL and triglycerides, about 21%. Ben, what information do you impart to your patients who have a high LDL cholesterol and a high HDL cholesterol? Does it protect?
So, I think patients with high HDL, live generally longer. It's very protective. That being said, there's a lot about HDL we don't know. To date, none of the studies that have ever been done with HDL, that being said, they were all on top of statins, haven't shown any difference with outcomes. In fact, niacin actually showed worse outcomes. So I think there needs to be a better understanding of how we can both assess and utilize cholesterol efflux capacity in these patients in order to better understand HDL and utilize it in clinical practice.
Yeah, so HDL cholesterol appears to be a good biomarker of risk, but not a target of therapy to load the particles up with cholesterol.
But Bob, could
Yeah.
add to Ben's?
Yeah.
I would never withhold statin therapy in someone with a high LDL because of a high HDL. I would never feel comfortable enough that the high HDL was protecting them, therefore they don't need to take a statin when I otherwise would have given them a statin.
Yeah, so that's an excellent point because
That's where the coronary calcium of 0 comes in. That's when you use it, is exactly that. I will,
I think you're more enthusiastic than I am about coronary calcium.
Well, but what would you say if they don't want it, their LDL is 200, their HDL is
Right, I hear it.
70 or 80?
I
It's
hear it.
very difficult, and family history is the best way of simply getting that. You look for people living into their 90s that are direct, upstream people. And if you don't have that, then that HDL may not be very active at all. And those are the ones, and you have a high HDL, and you get lots of calcium in their arteries. So I think both of those things will help in making that decision.
But don't you think that you have an LDL of 200? This patient should receive a statin independently of the calcium score?
Look, I'm telling you, there's a genetic risk we do not do, and those genetic risks that are totally sort of on a little chip, but we never do, have a big weight, and we don't see that. And so I wish it were just so easy to do, but it's not quite as easy as one would always expect. So you're always listening for these little hints that'll throw you off and maybe, but some look at the vessels themselves helps to make that decision.
It's only one snapshot in time, and if you have a very high LDL cholesterol of 200, you know, it's going to be very hard not to put them on therapy. And the question that Dan answered is that, you know, you get many, physicians that tell their patients your HDL cholesterol is high, you have heterozygous FH, but you don't have to be treated despite the family history. And I think that's the wrong answer. That's harmful to our patients. So thank you for clarifying that answer.
Since there have been a couple comments about coronary calcium scores of 0, I think we also have to keep in mind it's very age dependent, right? So a 40-year-old with a coronary calcium score of 0, I think, is totally unhelpful. Just to make sure.
What do you think about a 20-year-old with IMT increase? In other words,
Well, no,
a 60-year-old with IMT, there's your dime a dozen. That's not predictive of anything.
No, I
What if
agree.
you have
I
a
think
kid with
IMT is the test to use in younger people.
Yeah.
Absolutely.
Okay. So there's been a lot of discussion about CTP inhibitors, and I think a lot of us were quite disappointed with the termination of Accelerate, the evacetrapib study, because that agent lowered LDL cholesterol, increased HDL cholesterol, and in the paper, Dan was an author, published in JACC. There was an improvement in cholesterol-mediated efflux, but the study committee stopped the study, early. So first, I want to hear a little bit about the genetics of CTP and what do the Mendelian randomization studies tell us, and why has this been a failed target despite what those studies show. So Dan, and then maybe Juan can talk a little bit about the biology afterwards.
Well, just very briefly, the common variants that affect CTP and affect HDL go in the right direction, meaning the variants that seem to raise HDL, presumably due to reduced CTP activity, have a trend that is actually significant for reduced coronary disease, reduced cardiovascular risk. So consistent with the concept. But so far, the trials haven't quite lived up to that. So it's one example where we haven't quite gotten good concordance, and I think it's still a work in progress. I'll just say with regard to the efflux study, that it was very disappointing to me that evacetrapib increased efflux, and yet the trial was stopped. I will just say that the trial with the efflux was done using a previous formulation at certain doses. And also in that same study, high-dose atorvastatin blunted the efflux effect, and that's, of course, high-dose atorvastatin was used as the baseline therapy in the clinical trial. So I think we need to know more about the clinical trial. We won't hear about it till ACC, and then we'll learn.
So Dan, you bring up a very important issue is the context of evaluating HDL. And, high-intensity statins are doing something to efflux pathways, the MIR33, NISR, and then your work. And Jack, can you tell the audience a little bit about some of these interactions, with MIR33 and ABCA1 efflux?
Yeah, well, just briefly, statins do blunt cholesterol efflux effects, and it's not exactly clear why, but one may be through regulation of MIR33 expression in macrophages. I think it's interesting that statins have certain effects. Increasing Lp(a) is another one. Not everything goes in the right direction with statins, and some of these other effects may actually blunt some of the ultimate beneficial effects of statins. So
it wasn't seen with all statins. Rosuvastatin was, not so deleterious there. So I guess if you were to do another CTP study, if you had that courage, you'd probably pick rosuvastatin as your background statin. So Juan, can you tell us a little bit about, mechanisms whereby HDL cholesterol is increased, and how do they differ with regards to therapies that increase HDL particle concentration? How can we try and help sort this out from an experimental standpoint and a translational biology perspective?
Yeah, when we talk about the HDL, there is a problem that has been raised this morning. I mean, usually you have high HDL, you have low triglycerides. If you have low HDL, you have high triglycerides. And then the problem is, what is better? Because now we are learning a lot about the pathological role of triglycerides. Maybe the HDL is nothing else than the marker to tell you that you have to affect on the triglycerides. But before I go, let me ask you a question. I hate to go against nature, And CETP is going against nature. It's going against a protein that is there and probably to defend us, because the CETP sends the cholesterol from the HDL to the VLDL and the LDL. And remember, those lipoproteins, they also go to the liver. They also carry the cholesterol to the liver to be eliminated. And probably we are generating an unphysiological HDL, because I heard, and I don't know if it's true because I was not involved in the study, but France does not allow to enroll patients in the phase 3 clinical trial with one of the CETPs, because in the previous study, 6 months after stopping the treatment, the HDL cholesterol was still in the 100, when the lifespan of the HDL is about 48 hours. So the question is why the HDL associated to this treatment is so long-living. Maybe it's because it's not recognized by the regular metabolic pathways that we have, and maybe this is why it's not working. Another question that nobody understands, or at least I don't understand, in the defined trial, when you are giving a CETP, that theoretically the target is to raise the HDL cholesterol, in a patient that had less than 100 milligrams of LDL to be enrolled, show a 40% reduction of LDL, in addition to statin. So theoretically, with this, you have a drug that per se lowers LDL and in addition raises HDL. Why it didn't work? Maybe we're going against nature.
Right, so anacetrapib is very lipid soluble, and Gatto reported that you can detect blood levels of anacetrapib for years after discontinuing the therapy. And of course, it'll be very interesting if the study's favorable, how the regulators deal with that information. So CETP causes a polydisperse LDL. Dan, do you know anything about LDL receptor uptake in patients on a CETP inhibitor? Is it different from people not on a CETP inhibitor?
I don't think we really know the details. It's not clear even why CETP inhibition lowers LDL. I think it is partly due to increased LDL receptor expression, but also partly due to changing the particle in a way that makes it more amenable to LDL receptor uptake. But it does cause this polydispersed LDL, which must mean there are complexities of how it is affecting the particle that, I'll be honest, I don't think we fully understand.
So we have a lot of patients who have coronary disease with isolated low levels of HDL cholesterol, real challenge, until we get the ApoA1 mimetics or delipidation of HDL. In your paper in the New England Journal, you reported increased efflux with pioglitazone. Can you tell us a little bit about the PPAR pathway in terms of efflux, and do you ever recommend pioglitazone or one of those types of agents for people with a very low HDL cholesterol with coronary disease?
The PPARs do upregulate the ABCA1 pathway, and in theory might promote macrophage efflux in a way that would be beneficial. Of course, the clinical trial data haven't been quite as clear. Fibrates are relatively weak PPARs, and I think there may be greater effects of more potent PPAR alphas in particular, but I'm not sure we're ever going to see large clinical trials with more potent PPAR alphas, honestly.
So let's move on to triglycerides, another very hot topic. And Ani, can you tell us about what triglyceride levels concern you in terms of coronary heart disease and pancreatitis?
Traditionally, someone can correct me if I'm wrong here, but any levels above 500, I believe, in triglycerides is what we start treatment for. I haven't reviewed the data.
This is pancreatitis, not cholesterol.
But I generally haven't had many patients who've had extremely high triglycerides. Most of my patients actually are on statins, and I feel that they've already have that dealt with. But I don't know that.
Okay. All right. So Don, you want to comment about what triglyceride level you see chylomicrons and what triglyceride levels associated with pancreatitis?
Yeah, the number is 500. You start getting worried. Generally, 1,000, we always learn you to start treating at that point with something to lower the triglycerides to prevent pancreatitis. Usually, it's up even higher than that before you get to the pancreatitis. Some people quote 2,000 in terms of that. That's what's seen often in that. So they're so big, these chylomicrons, we're not concerned about the coronary disease. We're really concerned when the triglycerides get much, much lower. You get the changes in the LDL particle sizes and numbers, and that's where we get concerned. And so I would say I try to get down below 150, basically, is what you're always aiming for. And that's trial data that's driven that sort of number.
Yeah, so subgroup post hoc analysis, and we really need a good trial. And the strength trial, we're participating in here is a trial with omega-3 fatty acid, Epanova, that we're trying to find out if we can validate these subgroup post hoc analysis. So usually you think about chylomicrons at 880 milligram per deciliter, 10 millimole, and the Canadian study, as well as Bierman's work from the University of Washington, Seattle, showed it's about 1,500, 1,600 milligram per deciliter where you get pancreatitis. So Ben, you and I reviewed triglyceride-mediated pathways as related to coronary heart disease. Can you tell us a little bit about some of those pathways and how that's helped you with your understanding of triglyceride as a risk factor for atherosclerotic cardiovascular disease?
Sure. So, I think with the growing epidemic of obesity and diabetes, the pool of atherogenic lipoproteins as contributors to atherosclerosis is now being recognized, whereas previously it wasn't so much in the spotlight. So what we reviewed was, we saw that, and this is kind of what Dr. Rader was alluding to in his lunchtime discussion, was that these pathways are mediated by genetic variants. So, for instance, ApoC3 was one of the primary variants that seemed to show that it affected both VLDL synthesis and metabolism. ApoA5 really had a major effect on postprandial lipemia, and as a result, these are things that really we're just starting to recognize, and certainly targets of future therapy.
Okay. So Don, you have people that you see with very high triglyceride levels. Can you just give us a brief overview of what dietary interventions you're recommending, and tell us a little bit about your advice on activity or strengthening?
Yeah, you want to decrease all the fructose. Fructose goes into the fatty acid sort of cycle, the synthetic cycle. So fructose you're trying to reduce. You reduce all juices, all liquids basically that have almost any carbohydrates in them. And generally just reduce any sort of carbohydrate loads way down. People are eating enormous amounts of carbohydrates, as you're very aware, and as many of you may do yourself. So that's one thing to reduce them down. Exercise, as I just explained, is it increases the lipoprotein lipase, basically in the adipose and the muscular tissue, basically to get that energy out and to get the triglycerides in, and to make the triglycerides diglycerides so they go across the membranes for use as a energy source. So that's one thing. And then the other thing is just to decrease intra-abdominal fat. And so what's going to happen is when you start losing weight, the supply line basically for the triglyceride synthesis, the VLDL synthesis, is going to be cut. Now these are simplistic sort of notions, but I think that people will get them to a large extent, and hopefully gets them on the way where they're doing all three things. So those are the main things that I would do.
So what about aerobic activity versus strengthening? Any differences on lipids and lipoproteins?
On what now?
Aerobic versus muscle strengthening.
I don't know the data on that, frankly.
Actually, the
Why not?
Yeah.
ACCHA dietary guidelines show that they were the same. Maybe strengthening is a little bit better. It surprised me, but in that guideline from Bob Eckel, they reviewed the data extensively, and he talked at the National Lipid Association. In one of the plenary talks about that. So, a lot of people say, well, can I lift low amounts of weight and still get a benefit? And the answer appears to be yes.
May I say something? I honestly don't believe that for a second. I think it must be that they're, doing kind of people holding onto their towels and drinking their Avion, and they think they had a workout. The fact is that when what I've seen in my practice is that people really take it to heart when you motivate people, get connected to them, and they really become, reasonable aerobic athletes. The HDLs, they go from like 30 to 60. Yeah. The triglycerides disappear. I mean, they're dramatic, and you never see anything like that with weightlifting.
Well, it could be, repeated weights, light weights, but, many times.
That's bullshit. They gotta go out.
All right.
Bob, can I also, Don suggested that he tells patients to cut back on carbohydrates. So let me ask Don and others, does that mean they can eat as much fat as they want? And does it matter what type of fat they eat? Butter's back in, right? Saturated fat is fine?
Well, coconut oil seems to be back in. Disaster, right? I don't, that's hard, because I really am focusing on, first of all, getting those down and show them that they can do it. Once I show them that they can do things, then we can tighten up on what else they're
I'm just trying to be controversial.
No, but I think that's a good, quote. I mean, nuts have been a wonderful thing, and that's about the only thing I can think that can be healthy that will substitute for some of those, one at a time, right? So, anyway.
So Juan, can you tell us a little bit about triglycerides, endothelial function, atherosclerosis, inflammation, and do you consider this as a important pathway for atherosclerotic cardiovascular disease?
Well, I think that there are a lot of evidences that the triglycerides levels that are a prognostic, they have a significant prognostic value for a recurrent MI in patients that already had one. And it's very clear. But, and in addition, again, triglycerides, they are going to affect the endothelium, and therefore you're going to have all the problems associated with dysfunctional endothelium. Do you want to call it pleiotropic effects? It's fine with me. But we already know that if you affect the endothelium, you are going to have a pro-inflammatory stimuli. But before, I agree, if you can raise the good HDL with exercise, it does work. But the other day I reviewed the literature about the triglycerides, and it seems that the fibrates, nobody gave a damn about it. But I reviewed the literature, and even though in the famous accord, that they used to call it this accord, because we didn't learn anything, now we have the accordion and it seems to work, right? A longer follow-up. So basically, if you give fibrates, despite being a mild PPAR agonist, in a patient that has two criteria, low HDL and high triglycerides. And high triglycerides means more than 210, and low HDL means less than 40 for men and less than 45 for women. It's clear that in that subgroup, all the studies with fibrates, there is a significant benefit. Now, my question in the accord is, fibrates and statins do not work, or they were giving to people that they shouldn't be treated with this combination therapy. But again, if you have these two criteria, that by the way is written in the label of the fibrates, they do work. It works the cloffibrate, gemfibrozil, bezafibrate, fibrate, so it seems to be an effect of class. And I think that we cannot forget this, but you have to give it to the right population.
Yeah. Well, the ACCORD trial was a 2x2 by 2 by 2 by 2 by 2 study and maybe too complicated.
Yeah. But remember,
for the scientific question.
The same study is what we use to say that the combination doesn't work. Mm-hmm. So if before it was good, why now it's not good? Because we don't like the results. I mean, we have to be serious, and I think that the problem was that in that study, Henry and me too, I will not say they broke the rules, but they bent the rules in order to get all the patients on time. And then the noise was better than the effect, because again, you already said clearly, it's a mild agonist, but if you give it to the right population, it does work. Do you agree or not, Dan? No.
I believe if a well-done trial was performed in which people were hypertriglyceridemic and high risk and given randomized to a fibrate versus placebo, there would be a positive outcome. And you mentioned strength, which is not a fibrate, but a fish oil. But in fact, that's being targeted to patients with high triglycerides, which is really what the trials should do.
So I'm going to ask one question before we open it up to the audience. There's been so much focus on HDL cholesterol, and people say HDL when they mean HDL cholesterol, and the endothelial lipase polymorphisms, fail to show any difference in myocardial infarction risk, right? The Voigt paper. But there's other pathways that affect HDL that, at least in GWAS studies, look promising, like phospholipid transfer protein. How do we get an answer, for the HDL field, not the HDL cholesterol field? What steps are you taking, Dan, to incorporate some other metrics in HDL, maybe functional measures, to try and identify if there's any hope for the HDL pathway?
Well, Ben mentioned cholesterol efflux capacity. It's a very attractive concept that the more functional the HDL, the more ability it is to promote efflux, maybe the better it is, causally and protective-wise. So one way to do that genetically would be to measure it in thousands and thousands of people, look for the gene variants that actually are associated with efflux capacity and then ask, are those variants associated with coronary disease? So that's an experiment that's ongoing. I don't know if it's going to yield anything, but that would be one way to try to infer causality of cholesterol efflux capacity. And I think if that were positive, it would help strengthen that concept.
And I think one other concept that we can't dismiss is that you load up the particles with cholesterol, you're changing the surface proteins, you're shedding a lot of the anti-inflammatory, antioxidant, anti-infective proteins from the surface. So, maybe the large particles are not necessarily the most protective, and the small protein-rich ones may be the ones that we need to target for the future. So, Valentin?
You allow me to make 5 comments, 15 seconds each. Okay? Related to things that have been discussed here. The comment number 1 is about the dose of statins in acute myocardial infarction. We are working with a polypill, and we have been reviewed by the FDA and by the European Agency of Medications, and they accepted to start with 40 milligrams. So the polypill has 40 milligrams, because when you look at all the data together, the difference between 40 and 80 is minimal. And then you increase the side effects by 80. So both FDA and the European Agency have allowed us to start with a polypill with 80 milligrams, with 40 milligrams of atorvastatin. Number 2 was an issue discussed with the young population, and you should know we started a study in Canada, starting at age 35, for a 10-year study of 10,000 people, and it's all based in private practice, no academic institutions, and that is to follow people with high cholesterol levels and try to drop the cholesterol down in a randomized fashion to see if we should start all this game much earlier than just when the patients come at age 50, 60, or 70. Right. Third issue is about the calculator. And here I am talking more as an editor of a journal. The 2 articles are coming out, which I think are quite interesting. One was from Denmark. This is the Copenhagen Heart Study, in which they follow 10,000 people in terms of events, and they classify them like if you use the guidelines of 213 of the American College versus if you use the trials that you lower as much as possible, or if you use a hybrid approach, which one was able to predict the best in terms of the outcomes that they happen, and was the guidelines. And actually, I didn't expect this would be, because I have the similar feeling that you have, lower is better. But if you look at the data of the guidelines, they are entering more patients on statins than any other type of approach. So that means, in a way, you could intuitively feel that it's not so wrong, the guidelines. And that's actually, this is an issue. The final issue is the calcium score. And there are 2 studies coming out in JAG. One is the MESA formula, which you mentioned about it really works when you feed calcium score in the formula. But the most interesting aspect is the paper coming out in people who actually have 0 score, and you would give statins by following the guidelines. And in fact, if you take the 0 score, you should not give statins. This is coming out in the paper. So what we are saying is that many of these approaches that we take in trying to say more positive, a very negative calcium score, in a follow-up, I think, is of 10 years. It showed up that some of the people we give statins, we should not give them, or it's not necessary to give them. You cannot be dogmatic. And the calcium score is 0. And the final point I want to make is the side effects. Hadi, you didn't talk too much, but I love what you presented. All of us treat these patients, and all the trials talk about issues that are obvious. You stop because the CPK is high, your muscles don't work. But the reality of those of us who treat patients every day is so common, side effects, so common, it's so subtle, that when you stop the statin, doctor, I feel much better. And of many, many issues, and I cannot now describe. The only thing I'm trying to make a point here is we still should be doctors, all of us, when we give these statins, which is a fantastic enterprise altogether, and the benefits and so forth, but we have to be very careful and listen to the patients. Any patient who takes a statin, we should listen to the patient very carefully, because there are issues there that are very subtle. It could be side effects that are not really portray in any trial. Well, I'm sorry to maybe wasting your time, but I wanted to make these few points because are issues that I think are very hot and practical, and at least all of us are involved.
Okay, all right, thank you. So any questions from the audience? Pedro?
So having Dr. Rader here with us is a privilege, and we have followed patients both on a randomized basis and also anecdotally with intracoronary imaging, and quantify plaque regression by lipid core burden index and also by plaque burden. And we've seen how effectively these medications are in the large necrotic cores, in the plaques with LCBI greater than 500. But one thing that I don't understand is that simultaneously in the randomized trials done in Japan and others, they see a thickness of the fibrous cap. So it's easy to understand regression. If you drop the cholesterol, even with animals, you see it. Your macrophages goes away, lipid goes away. But why these plaques from fibrous caps average of 90 to 100 goes to 150? So there's a collagenesis associated with plaque regression. And this is my question. Just speculate to me this collagenesis in plaque regression.
Yeah, I'm sorry to tell you, this is well known in the literature. Not only that, you get calcification, it's a healing phenomenon.
Healing,
The moment you take
Healing.
cholesterol out, it's a healing phenomenon that starts with collagen synthesis and calcification. This is why you cannot follow a calcium score.
Because you have a healthy small muscle cells.
Because you don't have any idea how to interpret it.
Resolution of inflammation, exactly. I think it's part of the resolution of inflammation process.
Healthier smooth muscle cells.
And so there's no doubt that the statin reduces inflammation. I think that's probably mostly secondary to reduction in atherogenic lipoproteins. Some people think the statin is having other direct anti-inflammatory effects, and that hasn't been resolved. But, yeah.
Yeah, so statins also affect nuclear factor kappa B and reduce cytokine production, also circulating levels, and maybe that's due to oxidized LDL, but maybe not. So Jim Liao has, talked a lot about Rho kinase path. Sandy?
Yeah, I wanted to state two quick things. And one is that, getting back to the theme in the first place, I think it's no mystery how to stop this disease. I don't think it's really such a big deal, 99% of the people. I think, therefore, the problem is that how do you deliver the care? How do you find doctors who care about this issue? How do you find medical students who care about this issue? The medical industrial establishment is filled with, pushing buttons and creating glossy portfolios and advertising, but do they really care about this issue? And so how are you going to take what we know and actually deliver it? I think that really is the major issue of the day. I think that the second issue is, it's not so much the large vessels that become a problem then. It's the people who end up with the periventricular white matter stuff, the lacunar strokes, the chronic kidney disease, the diastolic dysfunction, all these potentially small vessel things that I think is really the next frontier that people have to start talking about more.
So, Ben, you took the lead on the paper in JACC, about statin utilization and how to address some of those challenges. Could you briefly talk about the highlights from your paper?
Sure. So one of the things, as Dr. Friedman was referring to, is that so let's say if you have a patient who's had an MI, now we're having shorter hospitalization stays. So one of the things is they're less likely to. So if someone comes in on simvastatin 20, they're less likely to change that to simvastatin 40. So that's the concept of that is clinical inertia. Another thing is that many providers, as you were saying, actually don't know this information, and that that kind of goes along with your data from CMS. And another thing is that they're not being referred to cardiac rehab, so they're not being monitored, and cost of medication is an issue, and so patients can't afford certain medications.
Dan, thanks. It was a great talk today at 12 o'clock. I did have a question for you, something I'd heard you present a couple of years ago about when you're taking people with FH or other single gene changes, making iPS cells and then correcting the defect, trying to make hepatocytes and then basically make a synthetic liver and putting that back in. Obviously a lot of work and a long-term goal, but could you update us on how that work's going in your lab?
There is a lot of interest in trying to use iPS cells to generate parenchymal cells like hepatocytes. We're not actively doing that right now. We are getting ready to start a gene therapy trial with AAV for homozygous FH with the LDIV receptor. Should dose its first patient within the next couple months. I think the problem with the early data with iPS hepatocytes back into mice is that poor engraftment and poor expansion of that pool to generate enough hepatocytes to have the appropriate metabolic effect. So that's not to say it's just early days. So I think that approach still might have promise.
Okay. I know Dan's got a train to catch, but if there's one more question, we'll take one last one. All right, well, I want to thank you for your visit. It's been really great.